all my stuff too. I'm assuming you all can see my shared screen.
Yes.
Yes, okay. So it's not letting me see myself as I share my screen, so I apologize for that. So I'm Dr. Rose with Cleveland Clinic, Akron General. And I just wanted to talk with you today about cognitive screening for adult psychiatric outpatients. So I'll just kind of begin and try to get this knocked out in this 20 minutes, okay? So disclosures, I don't have any disclosures. The data I'll present towards the end of this talk was collected as part of a quality improvement project at our outpatient mental health clinic. Learning objectives for this conversation are acknowledging importance of screening for neurocognitive disorders or cognitive impairments, the prevalence and diagnosis of these conditions, what cognitive impairment might look like, critically evaluating screening instruments, and comparing a study of 2 different screeners, as well as recommendations for what a screening process might look like in your own practice. So, importance of screening. Cognitive decline is a leading cause of functional impairment among older adults. So screening for these cognitive deficits can facilitate the early identification of these conditions. So identifying patients can help us to give them the appropriate treatment and referrals. So as clinicians, we can provide them with education to both the patient and their families, provide advice about what treatments or referrals may be appropriate, and help to monitor safety and adherence to treatment. So worldwide dementia, there's approximately 55 million people who have dementia, and this is expected to rise to 78 million by 2030. And this information is reported by the World Health Organization in 2021. There's a high cost for the treatment of dementia, which is just expected to rise over the next decade. Estimates of dementia in the US, where I'm at, is almost 6 million. And in Europe, it's closer to 9 million as of 2018. So there's specific risk factors we can look for when we're looking at individuals that may have either a mild cognitive impairment or a possible neurocognitive disorder. So of course, age is kind of this number one. Being older than 65, the occurrence doubles every 5 years. Also, if the individual has presented with mild cognitive impairment, so cognitive deficits that are not impacting their life significantly, but they're showing signs that we might not expect for their age group. But again, not significant, so that's why we call it kind of mild. Other psychiatric conditions can be increased risk factors listed there. Anticholinergic medications or polypharmacy, so being on, say, 5 or more medications can increase risk. Substance use, of course, repeated or severe TBIs throughout their life can contribute. Low socioeconomic status, limited education, those sorts of things can also be risk factors, as well as, of course, serious chronic medical conditions like cardiovascular disease or diabetes, increased risk for things like vascular dementia. So are we getting it right when we're doing these diagnoses? About each year, there's thousands of people misdiagnosed with neurocognitive disorders or dementia. So these incorrect or misdiagnoses do have consequences for patients. They can be harmful and expensive. They lead to inappropriate or missed opportunities for treatment. And they can also, being accurate, can avoid distress for patients and families. Getting a diagnosis of dementia would not be easy for the person or their family. So are we being mindful of, are we jumping to a conclusion that it is a neurocognitive disorder or dementia? So there's other things we can be ruling out before we kind of jump to that. So things like delirium, infections or conditions that may be impacting their mental status, conditions like depression or other emotional distress can present, and people often complain of cognitive changes, not necessarily a neurocognitive disorder. Do they have nutritional deficits? Are there medication side effects? Conditions or substance use or vision hearing deficits that could be contributing to cognitive complaints. There's 5 physician factors that were identified in this article about contributing to missed and delayed diagnoses by Bradford. Educational needs, so just having the knowledge about the diagnosis and detection of neurocognitive disorders, having concerns about consequences of missing a diagnosis, their attitudes towards dementia, like the stigma or the doubt that they can treat it or detect it, their comfortability with testing for dementia or selecting the appropriate tool, and communication, not feeling comfortable talking about dementia can be difficult with patients. Obviously, it's something hard for them to hear at times. So disclosing or explaining the condition, if they're unsure about that, they may be less likely to look for it. So the various neurocognitive disorders or dementias present in different ways at different stages in the progression of the disease. So this is just a chart outlining how some of the presentations may vary a little bit and what things may show up first versus later in condition. I won't go through all that for time's sake. So when we're looking to screen for cognitive impairments, or when we're doing more full neuropsychological evaluations, we're looking at specific kind of cognitive domains and seeing if there's deficits in those areas. So executive functioning, visual spatial skills, language and naming abilities, their ability to process information, attend to information, remember information, their ability to abstract, their orientation, their motor control, those sorts of things. So a screener, we want to kind of touch on each of these things, hopefully, when we're at least just even doing a brief screening process, but definitely covering these things when we're doing more full evaluations. So critically evaluating some of the screening instruments that are available. So selecting a screener, you just want to be mindful of, there's a tool out there, I can screen for cognitive disorders. What one should I use? Which one's valid? There's reliable ones that have been around for a long time. They're widely researched and used. One example is Montreal Cognitive Assessment, or the MoCA, St. Louis, Missouri Mental Status, or the Mini Mental State Exam. So the MoCA is one that can really detect symptoms of dementia. Some studies have shown 100% sensitivity and 87% specificity. This evaluates those cognitive domains I just mentioned. It kind of taps a little bit into each of those, which is important when we're trying to identify neurocognitive disorders. So here's just some tables of these widely used screeners, their sensitivity, specificity, how many items are on them, how long it takes to administer, what the score looks like, what cognitive domains they may look at. So this information, if you're looking for an appropriate screener, kind of doing a little bit of research and seeing which one might be a good fit for your practice in regards to time and how many items and what you're really going to be looking for. So in 2019, we did a comparative study. We chose the MoCA because we were already using this in our outpatient clinic, as well as when we were doing inpatient capacity evaluations. So this one we were familiar with. We know it's used a lot. It's well researched, a lot of information out there. But in our clinic, we were introduced to a new device. It's called the Cognivue. It was a newer technology. It seemed really cool. It's kind of its own standalone device, and I'll talk about it. So we wanted to see if the Cognivue kind of matched up to the MoCA that we had already been using and that we already know is a valid measure, because there's not a whole lot of research out there still on the Cognivue, but there definitely wasn't at that time. So the MoCA, if for those of you who aren't familiar with this, it's a 30-question a screener. 10 minutes to administer, so it does take some clinician time to sit down with the patient and administer that. And for some of us, having that extra clinical time isn't always easy, but when you do think there may be a neurocognitive disorder present, it's worth kind of setting that side of time to look at this. Areas measured, those are those domains we really want instruments to touch on. And there is a 1-point adjustment for education, so lower level of education, people do get 1 point, which is a little helpful. It is available in a lot of different forms and translated into a lot of languages. All of those can be found online. They all used to be free. The author of this and the kind of the governing body over it, I guess, or business, they now want you to kind of pay for the training, which is unfortunate, but I guess they want it to be really standardized across providers. So if you did decide, at the time we did it, it wasn't, but now it is. The scores range from 0 to 30. A score of 26 or more is considered kind of quote unquote in that normal range of functioning and not really flagging anything for cognitive impairment. The Cognivue screening device is a standalone device. Since this time, they've kind of downside. This is kind of the bigger version that we had at the time. Over the past year or two, they've made smaller versions of this that are more portable, some that take less time. So this device was developed to screen for cognitive impairment. It is FDA cleared, but basically that means there's no device like it, and it's a new device. There's not a whole lot to compare it to either. So it's 10 tests that are administered in 10 minutes. It's all on-screen administration. The clinician does not need to be present. They just need to review the printout that comes with this. More information about this can be found on their webpage. So the Cognivue says it measures things similar to the MoCA, those cognitive domains we want to see in a screener. It says it kind of touches on all those. It has a motor and a visual component largely and all across all the subtests. It says it calibrates for that. It's not really clear how it calibrates, but they say they kind of take that into consideration. So it won't negatively impact the score. They don't adjust for education. In terms of scoring, a score of 75 or greater is considered kind of in that normal range of functioning and isn't flagged, but anything under 75 is suggestive. So it gives you this nice clinician report, prints out for you of the various domains, gives you this average score, looks very nice and colorful. It tells you which tests fall under what domains, at least from their perspective, what it falls under. So critiques of their previous research. So a lot of their research has been company funded or is related to someone in the company in some way. There's only a few articles really published on this and only a few that are peer reviewed. So we on this article they published in the World Journal of Psychiatry, we had questions regarding kind of some of their findings and conclusions. They used the SLUMS and some other neuropsychological tests to compare the Cognivue to. But these tests weren't administered or interpreted by psychologists or anyone specifically kind of trained in that, which kind of leads to question the conclusions they drew from it. And then in the article, they talk about correlations with the Cognivue, but then they describe it as components, and some of the language isn't really clear. They did identify a few high correlations, but most of their correlations were low to moderate. And the cognitive domains measured by the Cognivue are really not well defined or researched in comparison to some of these other screeners. So there's limited research and again, mostly kind of funded by them. So the Cognivue and memory, is it kind of reaching this memory component? So it highlights it is. So the stimuli is presented on the screen, and after initial exposure of this visual stimulus, there's a few seconds that pass before the person is then asked to select or recognize what they just saw from a multiple choice format. So this is really a short-term memory process, not a long-term memory process. And recognizing stimuli is in a multiple choice format is much easier than having to freely recall it or encode the stimuli into long-term memory. So in some neurocognitive disorders, recognition can be intact in individuals. So this could lead to false negatives since most of the subtests of this, there's a big recognition component. They also, in their research, say there's a strong correlation between the SLUMS, which is another screener, and the Cognivue. But these tasks really differ. They're different tasks, and they're tapping into different areas of the brain. So the SLUMS naming task, the individual is asked to verbally generate as many animals as they can in 1 minute. Some of you may be familiar with a verbal fluency test like this. It's intended to screen for things like aphasia or other language speech disturbances. So that expressive language component is important. On the Cognivue, there's no expressive language, there's no verbal component, but they're presenting single letters or 3-letter words visually on the screen, and then the person is given that multiple choice format to then select what they just saw. So of course, some elements of language and identifying letters and those small 3-letter words, but it's not assessing the same areas that we'd be looking for in a naming task or something with verbal fluency or that requires word finding skills, which are common things that are impacted by neurocognitive disorders like Alzheimer's. So there's advancements in these cognitive screening processes, which are great, right? Digital computer-based tests really show promise for helping us to identify these, cutting down on time. Another common test, the historical clock drawing test, the paper pencil format, very common. I'm sure many of you are familiar with it. They've digitized it, which has been registered with the FDA, uses a tablet, a pen to capture and analyze the drawing. It has some limited research because it's new as well, small sample sizes when we're looking at some of this new technology. So not a lot of evidence or samples to show that this is really doing all these great things. So sometimes the technology comes before the research, and just more research is needed when we're looking at these newer devices. So in our comparison study in our outpatient clinic, we looked at adults 55 and older, and we asked them to participate, and we screened them over a 2-month period using the Cognivue and the MoCA. So the Cognivue and MoCA were given to each subject at the same time, but we alternated which one we gave first. MoCA was administered verbally, and then the Cognivue was just administered with the video directions they already have preloaded on the system. And then we collected additional demographics and information from patient charts. So the demographics for our sample, we had 58 participants, ages, big age range, 65% were female, majority were white or Caucasian, and 82% had 12 years or greater of education. And again, these are all patients being seen in an outpatient mental health clinic. So we compare how they did on the Cognivue to their MoCA scores. So on both screeners agreed that 16 of these people were negative for cognitive impairment, that nothing was wrong. But one or both of them said, there's 42 people here that are positive for some cognitive impairment. That's a pretty big chunk of our small sample, but a pretty big chunk. So of those 42, there was agreement between the screeners that 18 of these people have some cognitive impairment, like they're being flagged by the screener. Again, this isn't a diagnostic tool, it's just a screen, but they agreed that 18 people, something's wrong. But the screeners separately each identified 12 people as positive. So the MoCA said, okay, these people are being flagged, and the Cognivue, there was another 12 that they were saying is flagged on that device, but there was no agreement between these 24 individuals. So 12 separate people here. So then we looked at the differences and similarities among the people that were identified by only one screener. So here are some of the demographics there. We see the ones that in that first column that were only positive with the MoCA, that their score was kind of close to that cutoff on average. It was at 24, that cutoff is 26. And then on the positive Cognivue, we see a little bit lower there is around 63 when they were positive, but their MoCA score there was a 27, so close to that 26 again. Interestingly, all the positive scores that were only positive on the MoCA, they were all females. Don't really know what that means, but it's just interesting. There was more of an even split when they were positive on the MoCA. So then we broke it down even farther. We looked at correlations between the subtests. This actual table is very big. So we just kind of highlighted the ones here that showed some correlation. So we looked at all the subtests of the MoCA. We compared them to the various subtests on the Cognivue. We see a very big lack of agreement between the measures. So when you see the bigger table, there's a lot more things that aren't correlated. We wanted to see how well the Cognivue is kind of stacking up to the MoCA, which we know is tapping into these domains. A lot of the evidence just wasn't there. There were a few low to moderate correlations, which you can see in this table between the instruments and visual spatial abilities, naming, and attention, but most subtests were not well correlated. So our conclusions with this study, the Cognivue subtests appear to place cognitive demands more on visual ability, motor control, attention, processing speed, visual discrimination, and short-term memory or recognition. But having a deficit for a subject in one of these domains may negatively impact all their scores because all the subtests seem to have some elements of these cognitive demands. So if they have slow processing speed or problems with attention, they may have low scores across all. Subtests do not appear to be assessing long-term memory or executive functioning, language, or abstraction in the way that we would want it to when we're thinking from a neuropsych or a neuropsych perspective. Clearly defining the Cognivue subtest is crucial to determine its efficacy as a screening tool. And it just needs some more unaffiliated research to look at how well it's measuring what it says it's measuring. This study, of course, is limited. It's psychiatric outpatient clinic. This limits our generalizability of some of the data. It was a small sample size, so that limits our interpretation of these results. And this is our project team. Everybody's wonderful and put a lot of work into this. Our recommendations based on everything that we've talked about is that practicing clinicians should be aware of the importance of identifying cognitive impairments among older adults, and that screening tools play an important role in this identification, and they should not be seen really as an inconvenience, but as an essential part of optimizing patient care. So some of them that do take a little bit more time, it's kind of worth taking that little bit of extra time as opposed to not screening at all or just being unfamiliar with the process. Cognitive screening tools should not be chosen just because it's new or easily administered, or I don't even have to wait. I don't even have to take my time. I can have support staff put them on it and then I can just look at it. That's not necessarily the most efficacious way to accomplish these tasks. At this time, we recommend use of the MOCA despite the additional time and training that it now requires. There's a few other of those screeners that are also very good that don't have the associated costs. We propose that the Cognivue and other new screening tools be evaluated carefully by clinicians until there's sufficient research really to back it up, and that we can identify that these tests meet the standards that we need them to for reliability and validity. Key takeaways here: inadequate evaluation and misdiagnosis of neurocognitive disorders or dementia. These have consequences for our patients, so we need to be aware of those and be mindful of how we're impacting others. They can create anxiety, distress, inappropriate treatments, and expenses. We want to use valid and reliable screeners. Screeners aren't diagnostic tools, so just because a screener is positive doesn't mean the diagnosis applies. It just means that we need more information. We need to refer them out for further evaluation. So seeking collateral information is important when we're looking at neurocognitive disorders. Some individuals don't always have a lot of insight into these deficits. They may totally be unaware that anything has changed or in denial that anything has changed. So having close family or caregivers with the patient's permission provide you with additional information can be helpful. We want to make good referrals as needed. We want to rule out other factors that we talked about earlier on that could be contributing to the decline before we jump to conclusions. And we don't want to practice outside our scope, but we want to be familiar with these things. And we should always seek consultation, of course, and education as needed. So lots of references here, but that is all I have. I think I kind of stayed within my time, I hope. Now I can see.
Thank you very much.
You're welcome. Thank you.
That was amazing. Thank you so much for that presentation. It was quite insightful to understand the cognitive screening for adults in inpatients, and it's very interesting to hear about the screening tools and the recommendations and key takeaways as well. Thank you so much for that.